Good afternoon, everyone, and welcome to this presentation. I am Robert Anthonappa from the University of Western Australia, where I'm the discipline lead and program convener for pediatric dentistry. I am here to present to you on the topic oral microbiome in high-caries risk children. Nobel Prize winner Joshua Lederberg coined the term microbiome. Microbiome refers to the total sum of microbes, their genetic information, and the environment in which they interact. So in simple terms, the bacteria found in the oral cavity, including the tonsils and pharynx, are referred to as the oral microbiome. This definition of dental caries has all the key terms to describe the process. So it is a dynamic disease, multifactorial in nature, mediated by a biofilm, modulated by diet, resulting in the net loss of mineral tissue. In addition, there are other important factors, that is environmental, behavioral, psychosocial, etc., that can control or influence this process, resulting in the development of carious lesions. There are several models that have been published to describe the pathogenicity of caries. A contemporary model that describes the host microbe interaction is illustrated in this slide. As you can see, in a caries or a disease state, carbohydrates are fermented to organic acids, which will eventually lower down the pH, resulting in demineralization of the tooth surface. Importantly, this drives the selection of acid-producing and acid-tolerating bacteria, eventually leading to dysbiosis. On the contrary, in a healthy state, there appears to be a more complex and balanced pattern of metabolism, which involves the catabolism of salivary proteins and glycoproteins with the generation of alkali to neutralize any acids that may be produced. It is apparent that the biofilm undergoes multiple pH cycles during the day, resulting in enamel demin and remin. So obviously, if fluoride ions are present in the biofilm, fluoride is taken up in the superficial layer of the enamel during the remineralization phase, which will eventually slow down the demineralization during the acid challenge. However, if there are many risk factors, for example, there is insufficient time for pH neutralization due to frequent snacking, plaque being undersaturated with regards to fluoride, calcium, and phosphate, or if there is a low salivary clearance, demineralization eventually outweighs the remineralization, resulting in a net mineral loss with, in due time, leading to cavitation. These images represent early childhood caries, which needs no introduction, as this is a global health problem which affects more than 50% of preschool-aged children. Untreated caries lesions in the primary teeth have significant adverse consequences which impact both the child and their family's quality of life. In addition, if you are aiming at restoring or managing these carious lesions in young children, they require purpose-built facilities and significant resources, hence may be very expensive. Also, caries or carious lesions in children or children who have caries in their primary teeth are at a higher risk of caries in their permanent teeth, which will eventually interfere with their quality of life and other social activities. Now then, a common similarity between these two figures is one that both are complex. One is to do with etiology, the other one is to do with the burden of untreated caries in the primary dentition. The etiology of caries, although multifactorial, has some very key factors like the acidogenic and acidophilic microorganisms, the carbohydrates derived from the substrate, the host factors, and other social determinants like socioeconomic and behavioral factors that can play an important role in the whole pathogenesis. A paper by Venn et al. Recently described the burden, trends, and inequalities of untreated caries in both primary and permanent dentition between the period 1910 and 2019, and they looked at all global, regional, and national levels. The burden of untreated caries in the primary teeth accounts to roughly around 62.9 million cases in the primary teeth, directly attributed to cross-country socio-demographic inequality in 2019. This accounts to roughly around 12% of the global number of prevalent cases of caries in the primary dentition within the age group 1 to 4 years. There are several impact statements in this paper and would be a good read. I would suggest, if you get a chance, to go through this. Dental caries has a long history, with its nomenclature proposed in 1872 to a range of other hypotheses that have been published, from the acidogenic theory by Miller to the specific, non-specific, ecological-like hypothesis, to a point for the first identification of the human oral microbiome in 2007. So our initial understanding was that there are early colonizers on the tooth, which are mainly health-associated streptococcal species. Factors such as poor oral hygiene, high sugar diet, and other salivary and microbial factors can tip this balance, where the Streptococcus mutans produces a glucan matrix, leading to a robust biofilm formation and colonization of bugs, which are called as the late colonizers. Production of acids will eventually lead to demineralization and progression of caries.
However, in the last 10 years, there have been significant advancements in this sphere of analyzing the oral microbiome, starting from genome-wide association studies for caries to better understanding the analysis of active genes in species of microbiomes, which is referred to as metagenomics or metatranscriptomics. They provide a better understanding and insights into the etiology of dental caries.
The keystone pathogen hypothesis, as proposed by Haji Shingalis, indicates that it is possible that certain key low abundance bacteria can initiate an inflammatory process and change a normal microbiome into a dysbiotic one. For example, a model for dysbiosis illustrates that in health, a majority of the bacteria have a symbiotic relationship with the host. In simple terms, these microorganisms are shown in green. Sometimes potentially carcinogenic bacteria can be detected in healthy sites, and these are represented in red with dotted outlines. And again, these levels of these potentially carcinogenic bacteria are so low that they are not clinically relevant. They might be acquired either vertically or horizontally in transmission, but again, their levels would be extremely low relative to the bacteria associated with health. However, in a disease state, that is, in a caries state, there is an increase in the number and proportion of carcinogenic bacteria, and there may be increased biomass as well. For this to happen, there has to be some significant changes in the local environment, like major ecological pressure, which can alter the competitiveness of bacteria within the biofilm and select for those species that are more adapted to the new environment. There are a range of factors that can cause this dysbiosis, including factors like oral hygiene, diet, habits like smoking, salivary flow rates, activity of salivary proteins, conditions like diabetes, and genetic differences. Recent advances in the molecular techniques and the availability of next generation sequencing has replaced the conventional cultural methods to detect and analyze oral microbes that are involved in infectious diseases like dental caries. The samples that we currently potentially can use would be either saliva or plaque. Plaque can be supragingival or subgingival, and saliva can be stimulated or unstimulated. Upon collection of the saliva, the normal or an overview of the sequencing process includes extraction of the DNA, amplification of the gene, which is the 16S RNA gene with specific primers, then subjected to the sequencing, and then the sequences are grouped together according to the similarity into something called as the operational taxonomic units, which are referred to as OTUs, which are equivalent to each of those species, and then they're tabled, composition analysis carried out, and then illustrated. With that brief overview on the technique, in the next couple of slides, I'm going to share with you our experience sequencing a mouthful of microbes. This is a recent project that we explored, looking at the diversity of the oral microbiome in high-caries risk children and their mothers. 30 high-risk caries children and 30 mothers were recruited who were fit and well, free of any medical condition, who were able to donate 2 mL of unstimulated saliva. A clinical examination was carried out to estimate their, using the ICERAS criteria, to estimate their caries status. No use of antibiotics 2 weeks prior to donating the sample, and on collection of the sample, PCR DNA extracted, PCR amplification performed, sequencing using the next generation sequencer carried out, and then subsequently bioinformatic analysis, and the results in the next couple of slides I will show. And so for the results, the diversity and richness of the oral microbiome increased with the child's age. Also, the mean Bray-Curtis distance, where 0 corresponds to having the same microbes present and 1 to sharing no microbes between the children and their mothers, it appeared that that decreased with age. So the mean Bray-Curtis distance was smaller between mothers and children at 5 years of age. In simple terms, it appears that the microbial profile of children aged 5 years was similar to their mothers compared to ages 4 and 3. And for the microbial composition analysis, these 5 bacteria, Proteobacteria, Bacteroidetes, Firmicutes, Fusobacteria, and Actinobacteria, were the most dominant species, roughly accounting to about 80% from each group. The top 5 bacteria evident between the microbiome of mothers and children was Veillonella, Rotia, Streptococcus, Salmonella, and Acinetobacter. Finally, for the longitudinal relationship between the caries status and the oral microbiome dysbiosis, the children's caries diagnostic status significantly influenced the oral microbiome dysbiosis of Leptotrichia. And with the time limitations, I think it is important to kind of consider some of the learning points. A sample size of 24 based on previous studies appears to be adequate. However, if you can increase it to 30 to account for any unforeseen issues with sample collection and dropouts, that would be a reasonable sample to carry out the project. The most critical part, in my opinion, would be the type of sample that you would decide to use, plaque versus saliva, whether it is supragingival, subgingival plaque, stimulated or unstimulated saliva. The literature clearly indicates that there's going to be a variation in the plaque or in the microbial profiles, or depending on the sample that you would choose. That is, the microbial profile of supragingival plaque is different to subgingival plaque, and so it is different from stimulated to unstimulated saliva. So choosing a sample is critical. Some studies have used multiple samples like supragingival, subgingival plaque, and unstimulated or stimulated saliva. So it is up to the investigators to decide which way to go. Although sequencing 16S RNA gives you a good output about the oral microbiome, one of the limitations is that only gives you a taxonomic composition. That is, you only know what species are present and also tells you the presence and abundance of the species. Therefore, you can only do a conclusion based on observation, which sometimes is considered a limitation. Again, the study design is critical to the outcome of studies on oral microbiome. Most of the studies that are published in the literature are cross-sectional in nature, which should or will be considered a limitation. Again, the findings that I've reported is also cross-sectional in nature. Therefore, it is important that, if possible, to carry out longitudinal studies in terms of birth cohorts. There are some good birth cohort studies which will help determine the longitudinal changes in the microbiome corresponding to the child's age and development, which will be valuable in determining or making causal relationships. Also, it is important to have a control group to make comparisons and control for factors like socioeconomic status, oral hygiene practices, ethnic variations, and other risk factors to help make meaningful interpretations of your findings. This heat map is generated based on a bunch of keywords to illustrate the focus of cardiology research in the last few years. Streptococcus mutans obviously has been the center given its key pathogenic status. However, with the advent of proteomics, metagenomics, and a range of other approaches, it is becoming apparent that there are other players, and I hope that in the near future we get a better understanding with these approaches to help develop suitable, appropriate, preventive approaches to combat this global disease. Therefore, ladies and gentlemen, for millions of years, our Western microbes and us have co-evolved and coexisted in mostly a harmonious symbiotic relationship. It is clear that microbiome plays a significant role in our physiology and health. The oral cavity is the second most diverse microbial community in the body, which harbors more than 700 different species, which colonize on the teeth, the oral mucosa, the tongue, and other soft tissues. I've made an attempt to illustrate the recent advances in technology and what we can do and what we've started to do to unravel the complexities of the oral microbiome and gain better understanding or new insights into its role during both health and disease. And I think that better understanding is really important for us as practitioners and patients alike to promote a balanced microbiome, which is important to effectively maintain or restore oral health. Ladies and gentlemen, I thank you for your patient listening, and hopefully I've provided you some insights into this colorful world of oral microbiome. Thank you very much.